Most medical students and junior doctors will be able to recite the different clinical findings seen in upper versus lower motor neuron lesions. However, they may not be able to explain precisely how these features come about. Firstly, let's recap some basic neuroanatomy and the signs that we'd expect with different lesions. The motor system is very simple. There are only two cells involved, the upper and lower motor neuron. The upper motor neuron will begin in the primary motor cortex, pass down to the brainstem, where within the pyramids of the medulla, the fibers will cross and travel further down the spinal cord in the lateral corticospinal tract. The upper motor neuron will then synapse with the lower motor neuron within the anterior horn of the spinal cord. The lower motor neuron will then leave the spinal cord via a spinal nerve and innervate the effector muscle to bring about the desired movement. Weakness is associated with both types of motor neuron lesion, as disruption anywhere along this motor chain will impair the ability of the patient to generate voluntary movements. Upper motor neuron lesions are associated with increased tone, also referred to as spasticity, hyperreflexia, and clonus. Lower motor neurons, on the other hand, will cause a flaccid paralysis, hyporeflexia, wasting, and muscle fasciculations and fibrillations. I'm not going to be talking about the mechanics of lower motor neuron lesions in much detail in this video. However, a detailed understanding of the mechanisms behind upper motor neuron lesions will help you understand lower motor neuron lesions as well. In general, we tend to focus on the neural pathways that are responsible for voluntary movement, which is the corticobulbar tract for movements of the head and neck, and the corticospinal tract for the rest of the body. There is, however, another way in which our movements are controlled and our posture maintained. This is via the stretch reflex, which refers to muscle contraction in response to stretching of the muscle. This is what we're testing when we perform a knee-jerk reflex. Let's start off by thinking about why we actually have a stretch reflex in the first place. Imagine you're holding a tray with your arm. Your biceps are contracted to maintain this posture. Now, let's imagine that someone unexpectedly places a 2-liter stein of beer on your tray without warning. This will cause a passive stretch of your biceps, which will be detected by muscle spindles. These are specialized sensory receptors that detect how much and how quickly a muscle stretches or shortens. The sensory signal is transmitted via a sensory nerve to the spinal cord, where it synapses with the lower motor neuron of the same muscle fiber. The signal will activate the lower motor neuron, resulting in muscle contraction, allowing you to maintain the position of the tray with the stein on top. Note that this is a monosynaptic reflex that does not require processing or input from the cortex. This reflex is very important in the maintenance of posture by making rapid adjustments in the face of unexpected changes. In essence, your cortex has sent a command to maintain a certain position, which is holding the tray up, and your stretch reflexes can make the necessary adjustments if the muscles responsible for maintaining that position are unexpectedly stretched. Though this reflex arc can operate independently of higher input from the cortex, it does need to be regulated to prevent it from becoming excessively sensitive. As we mentioned earlier, the voluntary control of limb movement is carried out by the upper motor neurons traveling from the primary motor cortex via the corticospinal tract and synapsing with the relevant lower motor neuron. In addition to activating the lower motor neuron when a command is generated from the primary motor cortex, these descending fibers also have an inhibitory effect on the stretch reflex. This is because by inhibiting the stimulation of the lower motor neurons by the sensory muscle spindles, you can produce smoother, more coordinated movements that are directed by the cortex. At this point, I'd like to draw your attention to a couple of terms that you're likely to commonly encounter when reading around this topic. The upper motor neurons responsible for voluntary control of limb movement will pass down from the primary motor cortex into the brainstem and form structures within the medulla known as pyramids. This is why it's often referred to as the pyramidal tract. There are also several other descending inputs from the brain that come from outside the pyramids, i.e. extrapyramidal. These include the cerebrospinal tract, the vestibulospinal tract, and the reticulospinal tract. The details of these tracts are beyond the scope of this video. The key points I'd like you to retain thus far is that the corticospinal tract is responsible for voluntary control of movement below the neck, but it also has an important inhibitory effect on the stretch reflex. The extrapyramidal system works alongside the pyramidal system to achieve smooth and coordinated movements. The extrapyramidal system also has descending inputs that help regulate the stretch reflex. In a patient with an upper motor neuron lesion like a stroke, not only do they lose their voluntary control of movement, they also lose the inhibitory effect of these descending pathways on the stretch reflex. The disinhibition of the stretch reflex due to the loss of these descending inhibitory pathways gives rise to the classic upper motor neuron signs. The muscles are excessively stimulated via the stretch reflex pathway, resulting in increased tone or spasticity. This spasticity is described as being velocity dependent because the faster you passively stretch the muscle spindles, the greater the signal that is generated by the muscle spindles, and hence the greater the resulting contraction. The uninhibited stretch reflex will also mean that the patient is hyperreflexic. When you perform a knee-jerk reflex, essentially all you're doing is applying a passive stretch on their muscle spindles and triggering the reflex arc. Clonus refers to abnormal and rhythmic muscle contractions which are most commonly demonstrated in the ankles. The initial stretch placed on the gastrocnemius triggers the stretch reflex, causing it to contract. In the context of disinhibition, this reflex becomes hyperactive. The subsequent relaxing of the gastrocnemius after the initial contraction will trigger another stretch reflex, resulting in a cyclical pattern of contraction and relaxation, giving rise to the characteristic rhythmic foot movements. There are a couple of final points I'd like to make about this topic. First of all, upper motor neuron lesions may take some time to manifest the signs described. Though the mechanism is not completely understood, the acute phase after an upper motor neuron lesion, like a stroke, causes flaccid paralysis. This temporary loss of spinal reflexes is called spinal shock. After weeks or months, the spinal reflexes will come back and become hyperactive due to the loss of the descending inhibitory inputs. You may also see patients with upper motor neuron lesions having a pyramidal pattern of weakness. In short, this refers to flexion in the upper limbs and extension in the lower limbs. This occurs because all the muscles will demonstrate increased tone in upper motor neuron lesions, but the flexors are generally stronger than the extensors in the upper limbs, and the extensors are stronger than the flexors in the lower limbs. Finally, wasting tends to be more pronounced in lower motor neuron lesions. This is because in lower motor neuron lesions, the motor input to the muscle is completely severed. The complete lack of muscle stimulation will result in atrophy. Furthermore, the lower motor neurons also have an important role in providing various trophic factors that help maintain the integrity of the muscle fibers. On the other hand, in upper motor neuron lesions, the muscles will be excessively stimulated due to the disinhibited stretch reflex, meaning that atrophy doesn't tend to occur as quickly. Over time, however, patients are likely to develop a degree of disuse atrophy. I hope you found this video useful. If you like our content, please do like and subscribe, and check out our enormous online resource bank, the link to which is included in the bio. Thank you.